Dr. Javier and Dr. Antwiler is going to be discussing managing substance use and harm reduction. So please, warm welcome for Dr. Javier and Dr. Antwiler.
Good morning, everybody. So yeah, me and Dr. Antwiler, we represent the Department of Addiction Medicine. We've been providing medication-assisted treatment and medication for addiction treatments here at Eisenhower for the past 5 years. So we're going to be talking about managing substance use and harm reduction in the context of patients living with HIV. We have no relevant financial disclosures, financial relationships to disclose. For local data, since 2013 to 2022, there's been 967 cases of HIV that are diagnosed in Coachella Valley, averaging about 96 to 96.7 per year. So 96 patients are diagnosed with HIV every year since up until 2022. In 2022, 11,174 people living with HIV in the Riverside County alone. Palm Springs has 20 times higher prevalence than in all of California. There's reported the highest risk of transmitting HIV is receptive anal sex, and the second one is IV drug use. So the usual mode of intake for methamphetamine is smoking. Very rarely we see patients using IV. However, in 2022, there's been an uptick in the prevalence of patients using IV drug use, hence an increase in the diagnosis of HIV and transmission of HIV. About 50 to 80% of persons living with HIV reports current or past histories of substance use disorder, and depending on the study. So substance use worsens health disparities. So when patients are diagnosed with substance use as well, most often there's got to be a delay in HIV diagnosis because they're going to be concentrating on their drug use. There's reduced entry into care, there's reduced retention in care, delayed ART initiation, and inferior treatment outcomes. 66% of gay and bisexual men accounted for about 23,000 new HIV infections in 2019. So it really affects a lot of gay and bisexual men. 27% of Black African American, 31% of Hispanics, and 42% of white gay and bisexual men could have benefited from PrEP and post-exposure prophylaxis in 2019. 2 in 3 Black African Americans, or 62% and 67% of gay, bisexual men with HIV were virally suppressed in 2019, as compared to 3.4 white bisexual men. So what is the relationship of methamphetamine use with gay and bisexual men? Because of the minorities, there's multifactorial reasons why there's a high prevalence of methamphetamine use. So minority stress is a high stress environment because of stigma, discrimination, and marginalization, rejection by family, rejection by peers and society as a whole. The nature of the medication in of itself, the drug increases, the nature of it increases dopamine, it increases libido and makes sexual encounter a little bit more exhilarating. It was associated with the sexual liberations in the 1990s and the early 2000s. And also because of activities in the gay community, which enhances or encourage drug use, and now as Tim has mentioned, that's becoming normalized. And because of that, it's because of peer pressure. Often it has become intertwined with their identity, and this with the identity it's very hard to separate themselves from the using part. But this is this thing we call a triple stigma of being a sexual minority, substance use, and HIV as well. So it leads them further into isolation, and further isolation results to decrease access to care. So with acute intoxication, when it enters their body, be it IV drug use or inhalation, there's going to be causing a disinhibition. Disinhibition increased risk-taking behaviors, which could lead to multiple sexual partners, unprotected sex, transactional sex when you exchange sex for drugs, and also not disclosing, delay, or refusal to disclose HIV status prior to sexual intercourse. So I've mentioned there's going to it usually results to higher level of dopamine and increased interest in sexual activity. With chronic use, what happens is that it affects the frontal lobe of the brain, which is the executive. It's responsible for the executive function. When this is impaired, so there's also going to be an impaired inhibition control and therefore increased risk taking. Towards, it becomes a chronic use. The motivation to use is most often because they don't want to feel the negative effects or the withdrawals of not using. So these are usually manifested by low energy, depression, anxiety, insomnia. So most people, when it becomes chronic, just use because they just want to feel normal. And so that's what we call negative reinforcement. They don't get the euphoria as it did in the past, but they just wanted to just be able to, wash the dishes or even, take the trash out of the house. All right, so if HIV is complicated by meth use, the overall impact is just delayed or more rapid progression of HIV. So this is a schematic presentation of the potential effects of methamphetamine use can have an HIV disease. All right, we talked about epidemics, and so HIV epidemic and the drug use epidemic of methamphetamine epidemics, we call it a syndemic. They both occur in context with each other. So you have to treat them simultaneously. You don't wait for one to stabilize and then treat the other afterwards. It has to be treated simultaneously. A sample of 3,000 men who have sex or having sex with men have high prevalence of polysubstance use, depression, childhood sexual abuse, and intimate sexual partner violence, which all lead to independent HIV seropositivity and high risk behavior. Had an active effect on HIV risk, increasing number of risk factors, and high risk sex and HIV infection. All right. Some people, they're not amenable to stopping because it's highly intertwined with their daily activities, with their life, with their identity. And so we employ some harm reduction strategies to minimize the risk of transmission and also worsening of the substance use. So we meet the patient where they're at. So these are the several principles of harm reduction. So the benefits of harm reduction, we all know, decreased transmission of HIV, hepatitis C as well, just increased linkage to care. It also has, it generates healthcare cost savings as well. It reaches vulnerable populations and communities. So when people are engaged in harm reduction activities, there's more likely that they're also going to be involved in other resources as well. So they're going to be oriented with other services that are involved in the harm reduction strategies. All right, so I'll leave you with the rest of the treatment with Dr. Antwiler. Thank you.
So coming to screening, prevention, and treatment. CDC recommends that all individuals should be offered universal opt-out HIV screening for all individuals in healthcare settings. As per USPSTF, the recommendation is that all individuals 18 and older, they should be asked about unhealthy drug use, and if they are positive, they should be appropriately diagnosed, treated, and referred. And this is a grade B recommendation. When it comes to taking the history of a person struggling with a substance use disorder, you want to be mindful of the multiple psychosocial factors that are in play. This includes HIV status, housing status, mental health. A lot of these patients struggle with multiple traumas, they have multiple ACEs since childhood, so it's very important to develop rapport with them from the get-go. This is just an example of a quote from one of our clinic patients. "When I drink, I can escape from my regrets about my life and escape from the voice of my mother, always criticizing me. I thought I would be in a different place at my age. And this is from a patient who was struggling with alcohol use, tobacco use disorders, and depression. When it comes to treating substance use disorders, you want to follow an evidence-based approach. And one of the ways to do this are SSPs, or syringe services programs. And these are basically places where patients who use IV drugs can come to exchange their used needles and syringes for new equipment. This reduces the chances of sharing infected equipment, it reduces contaminated equipment from the community, and also reduces the risk of HIV and HCV transmission. Now, SSPs also provide other services. They provide HIV counseling, testing, STI screening. They help with distribution of Narcan. They also refer participants to substance use disorder treatment. And studies have showed that SSP participants are 5 times more likely to enter substance use disorder treatment. And there were 2 studies done based on this. The first one was done in San Francisco in 2005, and at a 6-month follow-up, SSP participants had no evidence of increased drug use. In addition, the participants actually who entered drug treatment had increased from 35 to 60%. And on a similar study in 2010 in Los Angeles, California, 53% of SSP participants had decreased drug use at the 3-month follow-up. Another evidence-based approach is pharmacological treatment. And there are 3 FDA-approved medications for opioid use disorder. And I'm not going to go into them in detail, but the 3 medications are methadone, which is a complete or full agonist, buprenorphine, which is a partial agonist, and there are 2 long-acting injectable versions. They're known as Sublocade and Brixadi. And there's naltrexone, which is an opioid antagonist. And that also comes in a long-acting injectable version known as Vivitrol. So for the first two medications, their impact on HIV prevention and treatment has been studied, and it's been shown to have decreased injecting and needle sharing behaviors, increased retention in HIV care, and increased antiretroviral treatment adherence. And a specific study was done on that, and that was known as the Beehive study. And it showed that the longer time a patient was on the buprenorphine naloxone combination, they had higher rates of antiretroviral treatment initiation and viral suppression. And to give numbers to that, it was pretty astonishing. It has a 69% increase in antiretroviral use and a 45% increase in viral suppression. Overdose is one of the most feared complications of opioid use, and there's been increasing contamination of the opioid supply with fentanyl. And CDC actually showed there was about 110,000 overdose deaths in the last 12-month period ending in March 2023. And one of the ways to combat this is Narcan or naloxone, which is an opioid antagonist. And our local SSP, which is Desert AIDS Project, actually has a harm reduction vending machine, which also provides Narcan, and our addiction medicine department also provides naloxone. In addition, another harm reduction strategy are fentanyl test strips. Patients can use the fentanyl test strips to basically see if their supply of cocaine, methamphetamine, or even heroin has any fentanyl. So they could consider maybe throwing it away or using it as a harm reduction strategy. In addition to fentanyl, there are other adult trends that are into play as well. So last year, we were heard of xylazine or tranq, and this year we're hearing more of medetomidine or rhinotranq. And medetomidine might sound a little bit familiar because it's a different form of Precedex or dexmedetomidine. So basically, these are adult trends that are added to the fentanyl supply. They're alpha-2 agonists, and they can actually lead to a worrisome complication, as you can see in the right, known as obliterative vasculitis. And this is why the drug is also known as zombie drug to that picture. And these adult trends actually lead to a more of a complicated withdrawal, which might lead to a longer time to manage the withdrawal symptoms. And this is just a short chart to show the amount of contamination that happens. So as you can see here with cocaine and methamphetamine, there's almost a 55% contamination found with xylazine. So a lot of patients don't know that they have xylazine in their supply. And this is just an example of a chromatogram of a random drug supply. And you can see here within that drug supply, there's about 5 different adulterants and contaminants that are being in play. You can see caffeine, medetomidine, xylazine, fentanyl, and a precursor of fentanyl. So coming to alcohol use disorder, there are 3 FDA-approved treatments to help with relapse prevention as well as for cravings. And the 3 medications are naltrexone, acamprosate, and disulfiram. Disulfiram is also known as antabuse, and it's been there since the 50s. However, at this time, these three medications have not been studied in terms of their impact on HIV prevention and treatment. Coming to stimulant use disorder, there are no FDA-approved medications at this time. However, there are two medications we are using off-label to help with the cravings and the relapse prevention. The first one is the bupropion plus naltrexone combination, and the second one is mirtazapine. There are other medications that are undergoing trials and studies, for example, like modafinil and topamax. However, the studies are not ready there yet for us to use. However, the mainstay of treatment for stimulant use disorder is psychosocial. So that includes CBT, the matrix model, contingency management, which is based on the premise that good behavior that gets rewarded results in good behavior. So that would mean negative urine drug samples get rewarded with gift vouchers or gift cards or money. And then finally, peer support. So on the note of contingency management, this is basically just a graph that shows the efficacy of contingency management. As you can see, the orange line, that's the percentage of negative drug samples that are seen when contingency management is used, and it is much higher. So coming to peer support therapy, we've all heard of this. We've heard of AA meetings, NA, CMA meetings. There are studies which state that 12-step involvement with facilitation is an effective evidence-based treatment and maybe even more effective than CBT. Now, there are alternatives to that 12-step model. So we have smart recovery, which is more secular. We have refuge recovery, which is based on Buddhist principles. And then we have LifeRing, which is also secular, but it's less didactic-based than smart recovery. And there are also other psychosocial treatments available as well. So in particular, there is Seeking Safety for patients struggling with PTSD and HIV. And there is also Artemis, which is a positive affect intervention for the MSM population. This actually focuses on principles of hope, optimism, and kindness. And this ends the lecture here. So as you can see, harm reduction is a spectrum. It goes from prevention, intervention, treatment, and post-treatment. So hopefully this lecture will help you all be able to utilize harm reduction for our patients struggling with substance use disorders and HIV. Thank you.
Thank you very much. Are there any questions for us?